I must warn you that I'm from the other side of the Yixkay, so you must correct my tenses as I go along. So English is very much my second language. So having that out of the way, I think the second thing I would like to say is that I was involved in HIV care at the Calafong Hospital pre-heart. And I remember those days fondly that I worked with Dr. Mariette Botha at the Calafong HIV clinic. And we gave dual therapy and monotherapy. Those drugs were things that we got from Swaziland at the time. I think HIV care has come a long time way since then. And I think you can remember this, because I remember this also fondly. And this was the first edition of the South African Journal of HIV Medicine. It was coincided, the first publication coincided with the 13th International Congress of AIDS that was held in Durban. And this was one of the articles that was published by Dr. David Britton, a clinical hematologist at the time. And at that time, I already decided that hematology is what I actually wanted to do. I didn't actually want to do clinical medicine. I wanted to do laboratory medicine. So it was really a very fond remembrance that I had of this article that was published in that very first edition of the journal. The outline is briefly going to be on the morphological findings in the peripheral blood, on the marrow aspirate, and then the Neutropenia marrow biopsy. And then I'm going to spend some time looking at quantitative abnormalities associated with the hematopoietic system, anemia, thrombocytopenia, neutropenia. I'm just going to say something about thrombosis, and I have a case study. So I think in terms of hematology, the hematological abnormalities are some of the most common features in HIV. And they are profound, and you can find them at the time when the patient actually gets infected and through the latent period in which the patient's asymptomatic as well. So it's not confined to advanced disease. And I think the things that actually happens is that we have direct effect of HIV on the hematopoietic tissue. That's causing also immune dysregulation, of course. And then the complications of secondary infections, of the drugs that we use to treat HIV and also to treat those opportunistic infections, and then the associated malignancies. We know that cytopenias are very frequent, and we know that these people have a predisposition, both arterial and venous thrombosis. And then I'm not going to say anything, and I think in terms of malignancies, the malignancies associated with HIV are beyond the scope of this discussion tonight, and I think that deserves a separate session to discuss. And we know that you have 50 to 200 times increase of non-Hodgkin's lymphoma. We know of the increased numbers of patients, 30% of patients with HIV that develop some kind of lymphoproliferative disorder will be Burkitt's lymphoma, and Hodgkin's lymphoma in about there is 8 times that of the general population in terms of development. Now, before I proceed, I would like to, it's something that we're not conscious of, but everyone that has a normal bone marrow in this audience produces about 10 to the power 12 new red cells each day. Just think about that, 10 to the power 12. As many red cells are removed by the macrophage of the reticular endothelial system. This is extremely impressive. Not only that, if you think about the bone marrow, and I know that, and what I'm trying to do is to give you some perspective as to what the bone marrow looks and what looks like in people with HIV and what we're seeing once we do the investigations on your behalf. So I want you to have a better understanding of the bone marrow. So if we do a bone marrow aspirate and we look at the tissue that we get and the specimen that we analyze, it comprises of the red cells and their precursors, the megakaryocytes that give rise to platelets, the granulocytes and their precursors. But those cells are not haphazardly arranged. The tissue is magnificently designed. So what will happen is those megakaryocytes that give rise to platelets will be in association with the sinusoids. And they will shed the platelets, which is actually just fragments of the cytoplasm of those large cells, into the circulation. At the same time, the red cells will be concentrically arranged around bone marrow macrophages, which we call nursing cells. And those macrophages supply the developing red cells with iron continuously so that hemoglobin can be formed. Next to the bony trabecles, we have the granulocytes maturing sequentially as well, in about 3 to 4 rows of cells. So it's a very organized tissue. Now, these are only the hematopoietic cells that are involved. Without the stromal cells, the milieu for hematopoiesis won't be normal, it won't be conducive. So these cells are the adipocyte or fat cells in the bone marrow, together with fibroblasts, together with lymphocytes, together with bone marrow macrophages, and so on. And they have a very particular function. What they do is they will anchor those developing cells of the different myeloid lineages to themselves by expressing cell adhesion molecules until those cells are mature enough to be released into the peripheral circulation. Only then will those cell adhesion molecules no longer be expressed. At the same time, they will produce all sorts of cytokines and growth-stimulating hormones to produce those cells and try and make them proliferate and differentiate into terminally differentiated cells. So it is very well organized, and I'll take you through it as we go along. So in terms of the primary infection, and I would like to refer to this person, Barbara Bain, and she is probably one of the most esteemed morphologists in the world. And she's an emeritus professor in London, and she wrote this paper in 1997 describing some of the changes that we see in HIV in terms of hematology. So initially, at the time when the patient has a primary infection, a lymphopenia will be short-lived, followed by a lymphocytosis, and usually these cells will be atypical lymphocytes. And then neutropenia, thrombocytopenia, low levels of platelets, and even transient pancytopenia can follow early on after this primary infection. And it can look very much like the Epstein-Barr virus infective mononucleosis associated with the Epstein-Barr in terms of the morphology of these cells. Following this, in terms of the asymptomatic phase, we get the reduced CD4 cell count, as we all know, and which is often masked by a lymphocytosis, increased numbers of CD8 cytotoxic cells. And at the time of AIDS-defining disease, these patients almost invariably, in the natural course of the disease, have lymphopenia, with or without pancytopenia, and various cytopenias in terms of different myeloid lineages. The anemia is usually normocytic, normochromic. In other words, it's normal-sized red cells, and they are normal in terms of the content of the hemoglobin. And sometimes they can be macrocytic. And this is an independent of zidovudine therapy, of D4T therapy. Also, the red cells, in terms of the morphology, will be abnormal. Anisocytosis, meaning different sizes, and poikilocytosis, different shapes of red cells are commonly found. We know that rouleau formation is also very prevalent, and rouleau formation means that these red cells are stacked like coins one upon the other. And how does that happen? What makes or affords these cells to do that? Because red cells usually carry a negative charge and would repel one another. And it's a function of the polyclonal gammopathy and the increased immunoglobulins that are circulating in the blood of these patients in the plasma. And that will also cause these cells to give a more rapid erythrocyte sedimentation rate. And that is why ESR is a useless test to do in a patient with HIV. It's of no value, really. In addition, we see increased background staining, and this background staining is also a function of those immunoglobulins that stain with the H&E stain that we're using to stain our slides when we do the microscopy of these films, blood films. Still in the peripheral blood, because that's always where we start and what we look at then, the neutrophils may show toxic changes and dysplastic features. In terms of toxic changes, and this is due to intercurrent infection, and I think there's always intercurrent infection, and we're not always, HIV-positive patients, aware of this. And I will make reference about it a little bit later on. So often we see a left shift, there's toxic granulation, increased granulation in the granulocytes, neutrophils, and so on, with Dolly bodies, and cytoplasmic vacuolization. And in terms of dysplastic features, these cells morphologically are abnormal. So they show detached nuclear fragments, which is the most specific finding in granulocytes in patients with HIV, unfortunately not so commonly seen. And then hypogranular neutrophils are often seen, occasional pulverization of the nuclei, and I'll show you what it looks like shortly. Bizarre nucleus shapes can often be seen, and what we sometimes see if the patient has a left shift is giant metamyelocytes, which is a precursor, earlier precursor of the mature neutrophil. Atypical lymphocytes, some even with lobated nuclei, is almost the norm in the peripheral blood of people with HIV. And large platelets may be present if there's immune-mediated thrombocytopenia in the patient. And this is just to show you what it looks like. So there we have a normal-sized lymphocyte. That lymphocyte is about 8 micrometers in diameter. And these red cells should be the same size as the nucleus of that lymphocyte. But you can see that these are much larger and oval shaped in relation to that. And this is macrocytosis, and this is typically what we see. Also, rouleau formation with the stacking of the red cells, and we discussed that already. And this is a left-shifted granulocytic cell. So this is a band cell that actually precedes the mature segmented neutrophil with toxic granulation. You can see these granules, and you see those blue inclusion bodies are called Dolly bodies, and they are actually rough endoplasmic reticulum that produce proteins that tells you that this cell is activated. So these are typical findings in terms of granulocytic series. Cerebellar UA changes include the nucleus, and we have hypolobated nuclei in mature cells, and you can see that they are also bilobed. And this is what we call cerebellar UA nuclei in the granulocytes of sites of patients, amongst others, with HIV. Now, this is a normal lymphocyte. If you look at this, you can see the nucleus is nice. It's 8 micrometers in diameter, almost the same size as the surrounding red cells, and that's very nice. But these are often the cells that we see if we talk about atypical lymphocytes. This is what they look like. They're much larger than that. They have an immature nucleus, and they've got much more abundant cytoplasm. And you can see this cytoplasm has a blue edge. We call it skirting. And one of my colleagues, actually, and also a friend in our department, call these promiscuous cells, because you can see how they actually, anything that comes close to them is actually hugged by this cytoplasm. Now we move on to the marrow. Those were the changes that we see in the peripheral blood. But if the patient has cytopenias, often the marrow will be requested. And there are 2 investigations in terms of the marrow, where you put a needle in the marrow cavity, aspirate the bone marrow, put it on a slide, and then spread it. So the architecture is no longer preserved. The value of the aspirate is to look at individual cells, enumerate those cells, and look at the morphology of those individual cells, as opposed to trephine biopsy, where the integrity of the tissue and the relative relationship of the tissue is preserved. And I'll show you that. So in the bone marrow aspirate, initially in the early stages of HIV, the bone marrow will be hypercellular, with hypocellular later in the natural cause of the disease. Initially, the cells look normal, but as time goes by, tri-lineage dysplasia becomes common. And what is meant by dysplasia? The cells are phenotypically abnormal. They look abnormal in terms of the way that they appear. And this has lots of implications for us in the laboratory, because dysplasia is found in myelodysplastic syndromes. It is found in people with megaloblastic anemia, and so on. So you can't make a diagnosis of myelodysplastic syndrome based on the morphological features in a patient that is HIV positive. That is something that needs to be excluded first before you consider a myelodysplastic syndrome. If there is dysplasia in the erythroid lineage, we call it dyserythropoietic changes, and those include nuclear lobulation, so the nucleus is no longer round, it has budding, it has fragmentation. Those cells may include Hal-Jolly bodies, which is a DNA remnant that's loose in the cytoplasm of those cells. You have more than one nucleus per cell, often by a multinuclearity. cytoplasmic bridging, where you have two erythroid cells that are connected with cytoplasm to one another, cytoplasmic vacuolization, basophilic stippling with RNA in the cytoplasm of those cells, and even megaloblastosis, where those cells are megaloblasts. And what we mean by megaloblasts, they are large, they have an immature nucleus with cytoplasm that's mature. So there's asynchrony between the maturation of the nucleus that's delayed and the cytoplasm that's actually mature. And that is typically what we see in megaloblastic anemia. And then this granulopoiesis, where the granulocytic series is abnormal, with giant metamyelocytes that are common. The megakaryocytes are increased in the early course of the disease. Later on, we see decreased numbers of megakaryocytes. And they also show bizarre nuclear configuration, often hypolobated, small dysplastic forms. And then, almost invariably in the marrow of a patient, there are reactive changes. And these are the things that we see. Increased numbers of lymphocytes, increased numbers of plasma cells. And the normal reference range for us is about 2.5% of plasma cells in the tissue of the bone marrow. And it is not unfamiliar to see 10, usually less than that, but we've seen up to 20% or even more plasma cells in the marrow of patients with HIV. Increased numbers of macrophages, and those macrophages can sometimes hemophagocytose the erythroid, platelet, and granulocytic series, and we call that hemophagocytosis, and I'll show you slides of that. Also, in chronic disorders, of which HIV is one, we often see increased iron in stores, and there's less incorporation into the sideroblast. And that is what we do, the Pulse reaction, so we want to see whether there is an iron transfer block. That's most usual. So if we look at the aspirate, and for us to be able to tell you whether it's cellular or not, we need particles. So particles, if the particles are absent, I can't tell you how cellular that marrow is. And this is an example of a very cellular particle, hypercellular. There are no fat spaces here. These are artificial cracks as the specimen is dried. So it's 100% cellular, and that is an empty particle with almost only fat spaces available and the architecture of the bone marrow particle, but no cells in it. So this is what initially you will see hypercellular, and later on it becomes hypocellular. And I would like to interrupt myself by saying, if we have a hypercellular marrow, meaning it has lots of these precursors of all the different lineages, and yet the patient has cytopenias in the peripheral blood, it means that there's ineffective hemapoiesis taking place. In other words, most of the cells die by apoptosis before they are mature to be released into the circulation. And we'll discuss that as we go along. So this erythropoiesis, and this is a feature of intercytoplasmic bridging. You can clearly see where this bridge actually spans from the one cytoplasm to the other of these two different cells. In terms of megaloblasts, and this is exactly what we mean by the asynchrony, the nucleus is extremely immature with the mature cytoplasm, and this is exactly what we see in megaloblastic anemia as well. You also see it in patients with myelodysplastic syndrome, and therefore you can't distinguish morphologically between those. Bare megakaryocyte nucleus is only the nucleus, it has no cytoplasm, and that is a feature that we often see because, and we will say it again, these cells are directly infected through the CD4 classification of differentiation 4 that is expressed on the surface that gains the access to the HIV virus. And then these are plasma cells. So typical morphology, eccentric nucleus, deep basophilic cytoplasm, perinuclear huff, and we see lots of these. They are even by nucleated forms. Bone marrow macrophages, this is what they look like. Nucleus there, very poorly circumscribed cytoplasm, and it has phagocytosed a lot. All of this debris is phagocytosed material. So active phagocytosis and hyperactive bone marrow phagocytic activity in HIV. That is almost the norm. If you go on to the Trophon biopsy where the architecture is preserved and you look at the changes, initially again hypercellular with increased neutrophils and megakaryocyte, especially initially. The marrow appears disorganized with poorly formed erythroblastic islands. And these erythroblastic islands is what I've spoken about earlier. Bone marrow macrophages surrounded by these developing erythroid precursors that gets fed by it. The megakaryocytes are clustered and they're very dysplastic with bare nuclei, and plasmacytosis and lymphocytes increase. Both of these are increased in an interstitial infiltrate, so diffusely increased throughout the tissue. You can get increased fibrosis as well. So the fibroblasts that form part of the stromal cells or the milieu of the bone marrow get stimulated by growth factor dysregulation to produce both reticulin fibers and collagen fibers that causes bone marrow fibrosis in the long run. And that causes a streaming effect of the hematopoietic cells. And in the later stages, again, it's a hypocellular marrow, and we often see gelatinous degeneration. Not only that, but also necrosis of the bone marrow. And then patients with specific infections may show granuloma formation. And in some series, patients with TB, 80% of those that have sufficient immune reserve will have granulomas in their bone marrows. And this is better assessed on the trophine biopsy than on the aspirate because the architecture is maintained. And this is typically what it looks like when you look at that biopsy specimen. Hypercellular, these are the bony trabecles, and between them, hypercellular bone marrow component. These are actually only fat spaces, empty hypocellular as the disease progresses. And then, again, a bony trabecle there. And this is gelatinous degeneration, where the individual cells can no longer be distinguished. It is just a pink amorphous material with the nuclei almost indistinguishable. And this shows you a granuloma. I'm sure I cannot see it so well, but I'm sure you can make out the outlines of this tissue. And this is typically what the granuloma looks like in the sections of a trophine biopsy on histology. Now, those are the changes, morphological changes. But let's look at the quantifiable things in terms of what happens in HIV. So anemia is in 10 to 20% of cases at the initial diagnosis, patients will be anemic, and 70 to 80% over the course of the disease. And the severity obviously is associated with the clinical stage of HIV, with 37% of patients with clinical AIDS that are not being managed in the normal progression of the disease being affected by anemia. And what are the causes? It can either be a reduced production of erythroid cells in the marrow, or it can be that the peripheral mechanisms is actually causing the anemia. So if we look at central causes in the bone marrow, CD34 colony stimulating these multipotent precursor stem cells that can develop into any one of the myeloid lineages, be it granulocytes, platelets, or red cells in terms of terminal differentiation, is suppressed. And we know that these cells express low levels of CD4, and the stem cells are directly infected by HIV that's causing them to produce less. That is probably not the most important feature. I think which is also very important is this, that the cytokines are abnormal. Now, I told you that these stromal cells produce all these cytokines and growth stimulation all the time so the normal hematopoiesis can happen. But now this system is dysregulated with abnormal patterns of cytokine secretion. So you get also tumor necrosis factor alpha, interleukin 1, and so on, which are inflammatory cytokines produced by the monocytes. And all of these things are not conducive to normal hematopoiesis, bedeviling this, in fact. And then also, vascular endothelial cells are part and parcel of the stromal cells of the bone marrow, and they are also directly infected, causing aggravated situation. There's a blunted response to erythropoietin, and therefore the erythropoietin receptors on the erythron will be less stimulated to produce erythroid cells. In addition to these, because those are the changes that are associated with HIV itself, there are other things that come into play. And these include the drugs that we treat patients with in terms of infections, nutritional deficiencies that are also common in patients with HIV because of malabsorption. Infections with viruses, parvovirus, EBV, we'll say something more about parvovirus, mycobacteria, and then new plasms that can infiltrate the bone marrow, of course. Anemia of chronic disease is probably the most important cause of anemia, and I think it's probably going to overtake anemia due to iron deficiency in a country like South Africa where we have a high prevalence of HIV. So, in terms of drugs, just quickly, AZT, we know that it inhibits erythroid colony formation, and it's in a dose-dependent fashion. It causes severe anemia, less than 8 grams per deciliter of HB, in 25% of cases of patients getting more than 1.5 grams per day. Macrocytes develop quickly, and that is also something that you can use as a surrogate marker for compliance. We know that it's not reversed if you give vitamin B12 supplementation or folate. And the macrocytosis is thought to be actually impaired red cell maturation. Amphotericin B suppresses erythropoietin production in the kidneys, and trimethoprim interferes with folate metabolism. So in different ways, they impact on the production of red cells centrally. Now, parvovirus infection on its own, we know that it's a single-stranded DNA virus, usually gets patients infected through the respiratory tract, invades the erythroids through the P group antigen. So you have different blood groups. It's not only ABO and RH. There are lots of different blood groups, about 28, 30, and P blood group is one of them. And that gains access to this parvovirus infection. So HIV positive people are unable to mount a humoral response with neutralizing antibodies, and this results in pure red cell aplasia because this virus infects the red cells directly, causing apoptosis, and there's a maturation arrest in those cells until you formed neutralizing antibodies, if that happens. So giant pro-normoblast, and a pro-normoblast is the first recognizable form of the red cell in the marrow, is seen in the bone marrow, but very little maturation beyond this, with an increased myeloid. So this refers to the granulocytes and monocyte ratio to the erythroid ratio in excess of 20 to 1. It should be in the region of 2.5 to 1. And 17% of patients that are HIV positive have been found to have evidence of a recent parvovirus infection with severe anemia. This article is old, 2004, but this article is excellent, and I can recommend it. Neil Young is the author. We had him out to the Federation of Society of Pathology a few years ago, and he is an authority on parvovirus, myelodysplastic, and bone marrow failures. And I can recall he was asked a question in the plenary after he made his presentation, and he told the delegate that asked the question, "I don't know," he said. No one knows. Now, if you can say no one knows if I don't know, you must be authority on this. So I can recommend this article on parvovirus B19. Also, why I've put this in and why I cut it here is, if I can ask you, is there a B17 and a B18 virus if you're talking about parvovirus B19? No, it's not. This was an incidental finding. In the mid-1970s, what happened is they were doing experiments to check for hepatitis B, and in position 19, row B, is where they found this abnormal reaction, and that's where the virus was actually diagnosed for the first time, and that's why it was called parvovirus B19. So this is the first recognizable form of the erythroid precursor, which we call the pro-normoblast, enormously large cell. If you compare it to the size of a neutrophil, it's got deep basophilic cytoplasm, and you see lots of these, even with inclusion bodies, in the nucleus, but no maturation beyond this point in patients with pure red cell aplasia due to parvovirus infection. And this shows you a bone marrow with lots of granulocytic precursors. There's a megakaryocyte, and there are no erythroid precursors here. Then, in terms of anemia of chronic disorder, which is the most prevalent, obviously, develops after 2 months. It's a mild hemoglobin reduction, 8 to 12 grams per deciliter. It's well tolerated. It is not progressive. These people are very seldomly symptomatic. In the pathogenesis, there are 4 reasons why. The one is that the lifespan of the red cell is reduced by 20 to 30%. The second thing is the patient has an iron transfer block, so the iron is not made available from the macrophages to those developing erythrocytes for incorporation in terms of hemoglobin. There is an increased erythropoietin production in the kidneys, and there's a blunted response in the bone marrow for the erythropoietin that is in fact produced. And these are all cytokine mediated by interleukin 1, for example, and tumor necrosis factor. And the laboratory features include usually normal sized, normal hemoglobin red cells initially. Later on they can become smaller and less well hemoglobinized. And if you do your iron studies and serum ferritin, the ferritin will be raised, but all the other parameters, serum iron, percentage transferrin saturation, and the transferrin levels will be low. Of course, doing a bone marrow aspirate and staining that for iron is the gold standard in terms of showing this. Now again, an excellent article, also on the old side, 2005, but this article by way is in the New England Journal of Medicine. I can recommend that for further reading for people that want to learn more about anemia of inflammation or chronic disorder. In terms of, if it's not the marrow that produces too few cells, what happens to those cells? Why does the patient become anemic? So peripheral causes. The patient may hemolyze. Microangiopathic hemolysis like DIC or TTP that's generally associated with HIV or other immune phenomena like autoimmune hemolytic anemia. And then hemophagocytic syndromes. I think we're probably underestimating the numbers of patients that have hemophagocytosis. Drug-induced causes, infections like CMV. Gastrointestinal hemorrhage, often due to mold lymphomas or some other gastrointestinal tract abnormality. And then, of course, hypersplenism always needs to be considered in a patient that has any form of splenomegaly. And that can result in a single cytopenia, bicytopenia, or even pancytopenia. I have one slide on autoimmune hemolysis, maybe 2. There's 18 to 77% of people with HIV that has a positive direct Coombs test without frank autoimmune hemolytic anemia, and this is common. So lots of laboratory tests are showing abnormal results without that translating into clinical and significant variability. So I think you just need to be aware of that. And this may be a function of the polyclonal gammopathy with the increased immunoglobulins. I think another thing that is valuable is this. What is the value of a full blood count in assessing your patient? It's fourfold to my mind. 1, we enumerate the hemoglobin and tell you how bad is the anemia in your patient. 2, we tell you, is it only anemia or is there something else? Is it a bicytopenia or is it a pancytopenia? Because you will think about other causes if we tell you it's a bicytopenia. Third, we tell you what the size and the shape of those red cells is to give you some impression in terms of the red cell indices, like what are the possible causes for this. And the fourth thing that we do is we tell you in terms of morphology whether they are red spherocytes, whether they are red cell fragments and so on, which will also help you. Reticulocytes form part, to my mind, of the full blood count in your initial workup of your patient. But beware, because there is ineffective erythropoiesis in HIV, the reticulocyte count is not to be trusted. It will be invariably low, and the patients will have a reticulocytopenia. So the reticulocyte reduction index will not be normal. And I think one should do some other tests if you think that there's active hemolysis. That includes the haptoglobins, LDH, the bilirubin fractions, especially unconjugated hyperbilirubinemia that you want to show. And if all else fails, do a marrow so that you can see whether there is in fact erythroid hyperplasia. Just to show you what it looks like, these are red cells on the blood film that are stuck together, agglutinated because of autoantibodies, usually cold antibodies, IgM. And what are the consequences of anemia? We know in HIV that its increased risk of death is independent of either the CD4 cell count or the viral load. It's associated with more rapid clinical progression of HIV infection, associated with decreased quality of life. It's a surrogate marker for advanced systemic illness. And we know that there's recovery from the anemia, and that's associated with improved prognosis. And this very small review article that was done by Moyle, an increased risk of death per 1 gram per deciliter reduction in the hemoglobin. If you have 1 gram per deciliter reduction in your hemoglobin, the increased risk of death were 41%, 57% and 14%, all significantly increased for 1 gram per deciliter. And I think that's significant. So in terms of anemia, what to do? Highly active antiretroviral therapy can correct and improve the anemia of HIV. We know that. Erythropoietin can also work, but I think the one prerequisite is that you need to show that it is the endogenous erythropoietin production is low, less than 500 international units per liter. And a weekly administration of erythropoietin has been shown to be as good as 3 weekly subcutaneous. Now we're moving on to platelets. We know that thrombocytopenia is common up to 40%, maybe the first manifestation of HIV in up to 10% of patients. And the severity also increases with stage. 8.7% of people with clinical AIDS will be afflicted. The degree varies with mild, more prevalent, and that's typical of HIV. It's usually a mild thrombocytopenia if it's not immune thrombocytopenic purpura. Spontaneous bleeding is rare in counts that we see usually associated with HIV, and we rarely see that patients bleed if the count is more than 10 spontaneously. Thrombocytopenia is a significant predictor of both all-cause and AIDS-related mortality amongst young women. That has been shown. In the era of heart, it is more commonly encountered in association with both two things: HIV replication, that's high, and hepatitis C co-infection. So I think that is something that we need to be able to show whether the patient has co-infection with hepatitis C. Okay, the most common cause for thrombocytopenia in people with HIV is, in fact, primary HIV-associated thrombocytopenia, and it differs from immune thrombocytopenic purpura, which is de novo ITP, in that it is associated with a higher risk of splenomegaly, less severe thrombocytopenia than we see in de novo ITP, and 20% will have a spontaneous remission. There is a normal or increased number of megakaryocytes in the bone marrow with reduced numbers of platelets in the marrow. So you see lots of these precursor cells, lots of bone marrow megakaryocytes, but very few free-lying platelets. There's increased platelet destruction because of antibodies, but, which is very important, is there's also ineffective or decreased platelet production, and that's been shown very well. So there are some mechanisms which contribute to these platelet destruction, and platelet antibodies against some of the glycoproteins on the surface of the platelets, 2B and 3A, cross-react with the envelope glycoproteins in HIV, 160 and 120. And there's complement-independent platelet fragmentation. Not only that, but these immune complexes can adsorb to the surface of the platelets and then opsonize those platelets for phagocytosis by macrocytes in the reticular endothelial system. So there's a significant decrease in platelet production, even in HIV-infected patients without thrombocytopenia. In various series, they looked at platelet survival, and in terms of this, decreased platelet production also in patients that are HIV infected on heart, off heart, and also patients with and without thrombocytopenia, and found that this was almost unanimous reduction in platelet production. Human megakaryocytes bear the CD4 receptors, and that makes them susceptible to direct infection, but platelets also have CXCR4 on their megakaryocytes and platelets on their surface, and that makes them even more susceptible to infection. And this has been shown in various ways ultrastructural abnormalities on EM, in situ hybridization is shown that these megakaryocytes are directly infected. And then we know that AZT is actually very effective in changing these, and causes also apoptosis in patients that bear the glycoprotein 2B3A on the surface. So how do we treat patients with primary HIV-associated thrombocytopenia? Zidovudine, clearly efficacious, and high dose is advantageous. HAART has been shown to be effective in increasing the platelet count. And we know that the patients that have discontinued HAART have dropped platelets again. Interferon alpha has worked in 66% of patients that were resistant to zidovudine in terms of platelet recovery, and it prolongs platelet survival. Intravenous immunoglobulin is expensive, it is hard to come by, and it is effective therapy, and it's reserved for patients that are bleeding now, or patients that you want a rapid increase in platelet count, for example, patients that have to go to surgery. We don't have IV anti-D in South Africa, but that is what you can use if you can get hold of it. It's safe and effective if the individual that's infected with the thrombocytopenia is Rh positive, so that's one prerequisite, and he still has to have an active spleen. Also, he should be able to tolerate the drop of 1 to 2 grams per deciliter in the hemoglobin, because that is often what will happen. Some hemolysis will take place. And then splenectomy is also effective therapy without rapid progression of HIV. It's been shown not to cause rapid progression. But beware of the fulminant infection that you can get with a capsulated organism. And the patient needs to be vaccinated against meningococcal, pneumococcus, and Haemophilus influenza. And you have to have your booster every 5 years. So that is important. And also, those patients should then also be vaccinated against flu every season. Cortisone gives similar results to patients that are not HIV infected with de novo HIV. However, you don't want to immune suppress a patient that has already immune suppressed. And there's a theoretical risk of fulminant Kaposi sarcoma in people that are infected with the human herpes virus 8. So we would like to stay away from that if at all possible. Secondary thrombocytopenia, so those are direct causes of HIV, but secondary thrombocytopenia can also be a result of opportunistic infections, malignancies, hypersplenism, and medication. And also, this was very interesting, that patients, some authors seem to think that patients that are HIV positive has a very high or much higher risk than normal individuals of developing heparin-induced thrombocytopenia, which is also an immune-mediated mechanism, where patients that are exposed to heparin produce antibodies against the heparin platelet combination, and that causes thrombocytopenia with microthrombi to form. This is just a blood film to show you what the normal platelet count look like in the relationship to these red cells. And this patient is thrombocytopenic with only about 2 platelets in the field. And this is what the marrow would typically look like. Increased numbers of megakaryocytes, low plodiform, they're small and they have round nuclei. They're supposed to actually look like this. Hyperplody, large cells, this is a normal morphology. But in patients with HIV and with immune-mediated thrombocytopenia, it will be increased numbers of low plodiforms, early precursors. A slide on thrombotic microangiopathy, because we know that it's more prevalent in people with HIV, TTP especially, with a pre-HAART incidence of about 1.4%. And hemolytic uremic syndrome, which is almost a cousin of TTP, is found later on and more refractory to treatment. And what happens is this. You have your vascular endothelial cells, they produce von Willebrand factor, they store it in Weibel-Pollard bodies. It's high in multimers, very active, that von Willebrand. You can't release it in the circulation, it's too active, physiologically too active. You want to cut it down, and there's a metalloprotease that does that. It's called ADAMTS13. But in HIV, patients can develop an antibody against that ADAMTS13. And the high molecular weight von Willebrand multimers are released. They're very active, and they cause micro thrombi of platelets to form. And that is the cause of TTP in patients with HIV. So associated factors that put patients at risk are higher viral loads and lower CD4 cell count, so it's progressive disease or uncontrolled disease, AIDS diagnosis, infection with Mycobacterium avium complex, and again, hepatitis C. The incidence has increased in the heart era, and this is also a nice paper produced in 2005 by Prof. Nick Nowitzki of Groote Schuur Hospital, in which they've shown that plasma infusion is effective to treat TTP in patients that are HIV infected, as opposed to plasmapheresis, which is still the gold standard. Much cheaper this if the patient can tolerate the volume. And this is what the blood film looks like with lots of red cell fragmentation in a patient with TTP. And DIC would look similar because red cell fragmentation is part of that group of disorders. In terms of neutropenia, 10% of patients that are in the early asymptomatic and symptomatic phase will have neutropenia, 50% or more in advanced disease. And there are multiple reasons for this. And again, inhibition of the granulopoiesis by the virus of the stem cells themselves. And then abnormal cytokine milieu, again, marrow infiltration by opportunistic infections, also systemic infections, drugs, autoimmune neutropenia. And we know that 30 to 60% of people that are HIV positive have antibodies against neutrophils, which is staggering. And then again, hypersplenism, that also always feature here. Not only do you have less neutrophils often, but these neutrophils are not functioning properly. In what way? They have abnormal Fc binding of macrophages. Opsonization is impaired. And opsonization means the way in which particles are made visible to and bind to the macrophages. And then there's decreased killing, both oxygen-dependent and independent, by the neutrophils. So the risk factors in patients that are neutropenic, what does it mean if you have a neutropenic patient? 2.3-fold increase in the risk of infection if a patient has a neutrophil absolute count of less than 1. It increases to 7.9-fold if it's less than 0.5. And the incidence of bacteremia has increased 14-fold in a patient with an absolute neutrophil count of less than 1. There's an increased frequency of hospitalization amongst people that are neutropenic. And then there are studies that show that there's a risk for serious infection and complication in neutropenic HIV-infected patients. But retrospective studies, because those were, as suggested, there's an increased risk of mortality in patients that are neutropenic with HIV, but prospective studies have shown that it's not the case. Okay. Mild to moderate neutropenia may be managed in terms of heart, but G-CSF at 5 micrograms per kilogram per day is also effective. And it's also shown to improve the function of neutrophils. It's effective in preventing neutropenia and also the bacterial infections associated with this, also the numbers of hospitalization in terms of days. And it is justified to give a patient Neupogen if the patient has had bacterial infection in terms of preventative measures. In terms of venous thrombosis, the incidence of thrombosis were judged in a few series amongst more than 42,000 patients that are HIV infected. It was shown to be 2.6 per 1,000 patient years. And for clinical AIDS, it went up to 6.2. And the factors associated with the risk included age more than 45 years, CMV infection, hospitalization, megestrol acetate that was used for patients that were cachectic and indenover use. Another study showed to fail a significant difference between the rate of thrombosis between HIV positive and negative. And this was a prospective study, except for patients that were less than 50 years old. And they said that the patients has HIV infected rate was 3.31 versus HIV negative controls of 0.53. It didn't hold any statistic significance in terms of difference. Retrospective review of medical records of more than 37,000 1,000 HIV-infected patient showed that the patient infected the age and range and site match controlled a 39% increase pre-heart and 33% increase post-heart in the risk of thromboembolic disorders. And I think that's important. So I think in the end, when all is said and done, there is evidence to suggest that these patients are at increased risk for both arterial and venous thrombosis. And what are the causes? Increased levels of pro-inflammatory cytokines, interleukin-1, 6 tumor factor, necrosis factor alpha, which causes an increase of factor 8, which is an independent risk factor for thrombosis in any individual. Reduced levels of protein S associated with HIV, and reduced expression of the proteins necessary for active fibrinolysis of clots that get formed. And acquired deficiency of protein S and C and heparin cofactor 2 also predispose people to thrombosis. High titers of anticardiolipin antibodies have been shown in people with HIV, and then again the endothelial damage, and you all know Virchow's triad, that it is either stasis that causes venous thrombosis or hypercoagulability of blood or vascular endothelial damage. And then risk factors, independent risk factors associated with thromboembolic complications in HIV is hospitalization, opportunistic infection, coexisting malignancy is a very high risk, indwelling central venous catheters always, progressive disease with lower CD4 cell counts and higher viral loads, elevated levels of factor 8 and homocysteine, elevated lipid levels, increased tissue factor expression. And I think this is important because there's monocytes that has tissue factor expressed on the surface, and that tissue factor is thromboplastin. That is the reagent we put into the tube to do a PT test together with calcium to clot the blood. Now, in patients with HIV, because of gastrointestinal abnormalities, there is the whole time bacteria and bacterial products that causes lipopolysaccharides to activate these monocytes, and the monocytes that are activated in this way express tissue factor, causing a micro microparticles that actually stimulates thrombosis formation. And then the presence of antiphospholipid syndrome is important, and reduced protein SC and antithrombin are independent risk factors for thrombosis associated with, and these are acquired conditions in HIV. Okay, this is a 49-year-old male patient with HIV positive, which is evaluated for HIV. 11 months earlier, he discontinues his ARV because of lipoatrophy and pill fatigue. He has progressive fatigue. He's lightheaded when rising from sitting to standing, cannot perform the activities of normal life, lost 5.4 kilograms in the previous 6 months, no fever, no chills, night sweats, chest pain, none of these, no diarrhea, no dysuria, but a history of chronic fatigue, depression, short-term memory loss, arthritis, hypogonadism, allergic rhinitis, asthma, irritable bowel syndrome, and gastroesophageal reflux disease on all of these types of medication. So a whole list, including valproic acid. And on examination is afebrile, and anemic, without edema or petechiae, no submandibular, cervical, or supraclavicular inguinal lymphadenum palpable. Pulse rate is 104 per minute, 16 respiration per minute. Blood pressure is fine. He appeared fatigued, lipoatrophy of arms and legs. Lungs were clear. Rest were really without any significance. And if you see this table of the values, he had a hematocrit of the hemoglobin was 5 weeks before the evaluation 11.3, 3 weeks before 10.5, and then on examination 6. So a significant drop in a very short period of time, actually, in terms of hemoglobin. The absolute neutrophils were also low, with a white cell count 2.6, and you can see a steady drop from 5.2 5 months earlier. And then platelet count was actually not of a lot of interest, and the direct Coombs test was positive. But apart from that, nothing specific. So the considerations, and I think the important things to consider, is the rapidity of onset of the anemia. It was rapid in the case of this individual. Is the anemia isolated, or are there other hematopoietic lineages that are affected? We said something about that. And the possible causes in this patient include hemorrhage, hemolysis of the red cells, hematinic deficiencies, marrow infiltration, viral infection, and medication-associated bone marrow suppression. And then the bone marrow aspirate were done together with a biopsy, and this is what was seen. So it's hypercellular. You can easily see that. Paucity of erythroid precursors, and again with this large pronormoblastic pronormoblasts, and virtually no maturation in the bone marrow. So we know from this that the patient is probably having a pure red cell aplasia, because you see these early precursors of the red cells, but there's no maturation, and the ME ratio is raised. What are the possible cause drugs, including anticonvulsants, infections, again, neoplasms, and these things need to be considered. The bone marrow findings confirmed the pure red cell aplasia. So the valproic acid was immediately discontinued and heart was initiated again, because they thought that let's exclude HIV as a possible cause for the pure red cell aplasia. Viral load improved, but the patient remained anemic and transfusion dependent. The working diagnosis was made of a pure red cell aplasia. Prednisone was started. And then the next day, the patient became febrile. Blood culture showed salmonella sepsis. Prednisone was immediately discontinued. Appropriate antibiotics administered. CT of the chest was also done to check for thymoma, because thymoma is also associated with pure red cell aplasia. And then this was discovered. Supraclavicular lymph node on the left, and these large mesenteric root lymph nodes as well. Biopsy was performed, and that showed of that supraclavicular lymph node, these cells. So large cells within a population of lymphocytes, and they are Reed-Sternberg cells, and the diagnosis of Hodgkin's lymphoma was made. So this is a case of a patient with aplastic, a pure red cell aplasia associated with Hodgkin's lymphoma in HIV. And I think this is these things are things that we see. I'm not going to present the next case study, but I think something that is actually not diagnosed and underestimated is the number of patients that present with hemophagocytic syndrome in HIV. And they did a post-mortem on 56 patients that died of AIDS, and I think 20 of those patients on post-mortem had evidence of hemophagocytic syndrome, actually, that weren't diagnosed in life, but at post-mortem. And I think that is something that we need to consider as well.